हेलो बच्चों, क्या हाल चाल है? जस्ट गिव मी अ क्विक confirmation first of all that I am visible and that I am audible because I just came back from a very important emergency at the hospital. That's why I'm a little late. So first give me a quick confirmation that I am visible and that I am audible. Are we good to go? Hello, are we good to go? Hello बच्चों, क्या हाल चाल है? I think yes, we are live. So today's session is going to be on important radiology spotters. And as you all know, we are starting with the Farre series today. तो आज हम बात करेंगे कि चेस्ट एक्सरे को कैसे रीड करते हैं, बिकॉज फर्रे सीरीज का क्या पर्पस है। फर्रे सीरीज में हमें पता होना चाहिए कि एग्जाम में क्या क्या पूछते हैं, प्रॉफ बेस्ड एग्जाम में क्या क्या पूछते हैं। दैट इज अवर मेन गोल। थैंक यू सब्यसाची, सो नाइस टू सी यू गाइस। Thank you, Surajay, for that confirmation. Good evening, Satyajit. Wala, how are you? How is everybody? How are things going? So we'll wait for a couple of minutes and then we'll start. Hello, good evening, MBBS 8981. Hello, hello, hello. Yes, yes. So nice to see you all. Acha, by the way, I'm sure all of you know about the PW MedEd 1 plan. So अब सब कुछ एक ही प्लान में है, बड़ा सस्ता प्लान कर दिया अलग सर ने सब लोगों के लिए। 5000 फॉर 1 ईयर, एवरीथिंग, मेन वीडियोस, रिविजन वीडियोस, फर्रे, प्रॉफ, एवरीथिंग। हेलो मुकेश, गुड इवनिंग। Raj Parmar, is it useful for NEET PG or not? Not so much for NEET PG, I'll be honest. It is mainly oriented for MBBS professional exams and fourth final prof students, ठीक है। सो आई बी लिटिल ब्लंट, मैं ओपनली बोल रहा हूँ, नीट पीजी पर से के लिए आज की क्लास नहीं है, थोड़ा बेसिक कंसेप्चुअल क्लास है एमबीबीएस स्टूडेंट्स के लिए। Frustrated about exams? Why are you frustrated, MBBS 8981? What's your name? MMBS 8981, what's your name? Good evening, Mukesh. How are you? Good evening. Good evening, Pratyush. Hello, hi. Help me in passing my prof exam, sir. हाँ यार, उसी के लिए वही, दैट इज द मेन एम, तभी हम ये सीरीज कर रहे हैं आपके साथ। ठीक है। हार्ड कॉपी ऑफ फर्रे मिलेगी? हाँ मिलेंगी, हार्ड कॉपीज भी अवेलेबल हो जाएंगी। वो सब भी आपको मिलेंगे। अच्छा, महेश नाम है, ठीक है महेश। सो आई विल बी हैविंग माय प्रॉफ बाय March 25th। ठीक है, तो कोई बहुत टाइम है अभी तो। प्रॉफ एग्जाम्स तो पास हो ही जाते हैं, डोंट वरी अबाउट प्रॉफ एग्जाम्स, दैट्स नॉट एन इशू। अच्छा, वॉइस इको तो नहीं हो रही है ना? वो एवरीथिंग इज फाइन, यू कैन हियर मी? स्टार्ट करें फिर क्लास? एनी अदर स्टूडेंट्स? शुड आई वेट फॉर समवन एल्स? चलो, लेट्स स्टार्ट टुडेज क्लास। तो आज हम बात करेंगे हाउ टू रीड अ चेस्ट एक्सरे एंड विल आल्सो कवर फ्यू इंपॉर्टेंट रेडियोलॉजी स्पॉटर्स। तो आज की क्लास में हम क्या क्या कवर करने वाले हैं? हाउ टू रीड अ चेस्ट एक्सरे, इंपॉर्टेंट रेडियोलॉजी, रेस्पिरेटरी रेडियोलॉजी स्पॉटर्स, बिकॉज सबसे कॉमनली रेस्पिरेटरी रेडियोलॉजी के ही स्पॉटर्स पूछे जाते हैं एग्जाम में। देन हाउ टू रीड बोन ट्यूमर्स एंड these three things will cover in today's class. तो फर्स्ट ऑफ ऑल लेट्स सी कि नॉर्मल एक्सरे लेते कैसे हैं। सो अगर आपने कभी रेडियोलॉजी डिपार्टमेंट विजिट किया होगा, मैं बोल रहा हूँ कि अगर आपने करा होगा, बिकॉज मैंने एमबीबीएस टाइम में नेवर विजिटेड द रेडियोलॉजी डिपार्टमेंट। आयरनी ये हुई कि आई जॉइन रेडियोलॉजी लेटर, बट एमबीबीएस में मैंने कभी रेडियोलॉजी नहीं देखी। ठीक है। सो अगर आप ऐसे स्टूडेंट हो जिसने एमबीबीएस में रेडियोलॉजी देखी है, आप एक अच्छे स्टूडेंट हो, आपने अपना डिपार्टमेंट देखा है, तो यू वुड हैव नोन हाउ टू टेक अ नॉर्मल चेस्ट एक्सरे। सो आपने टिपिकली देखा होगा, सामने प्लेट होती है, उसको आप ऐसे हक करते हो, पीछे से रेज आती हैं। द रेडियोग्राफर सेज लंबी सांस लेके रोकिए। सो यू टेक एन एक्सरे इन फुल इंस्पिरेशन एंड आर्म्स रोटेटेड एंटीरियरली। ठीक है, दिस इज नंबर 1 पॉइंट। नंबर 2, कि जो डिटेक्टर है, डिटेक्टर हमारे आगे होता है एंड रेज आर कमिंग फ्रॉम बिहाइंड, दैट इज नंबर 2। तो जो डिटेक्टर और एक्सरे ट्यूब के बीच का डिस्टेंस होता है, ठीक है। सो इफ दिस इज द एक्सरे ट्यूब, दिस इज द डिटेक्टर, यहां पर आप खड़े हो, दिस इज नोन एज द फिल्म फोकस डिस्टेंस और एफएफडी, फिल्म फोकस डिस्टेंस। चेस्ट एक्सरे के लिए क्वेश्चन आता है कि ये इज, दिस डिस्टेंस इज 6 फीट। ठीक है। सो दिस इज इंपॉर्टेंट फॉर चेस्ट एक्सरे। नॉर्मली कैसे लेते हो? नॉर्मली पेशेंट टेबल पे लेटता है, ऊपर से एक्सरेज आते हैं, एंड नॉर्मली ये डिस्टेंस 100 सेंटीमीटर होता है, 1 मीटर। पर चेस्ट एक्सरे के लिए इट इज 6 मीटर्स, सॉरी इट इज 6 फीट, 1.8 मीटर्स। ये इंपॉर्टेंट याद रखना। एंड टिपिकली एक्सरे को हम बोलते हैं पीए व्यू। वाई? बिकॉज रेज आर कमिंग फ्रॉम पोस्टीरियर टू एंटीरियर, योर फिल्म इज एंटीरियर। ठीक है सर, तो दिस इज द इंपॉर्टेंस। अब पीए व्यू को क्यों लेते हैं हम? क्योंकि अगर मैं आपको डिटेक्टर, इफ आई ड्रॉ द डिटेक्टर, if I draw the normal chest cross section of the patient, ये patient यहाँ पे खड़ा है, this is the detector and rays are coming from this location, right? Now, patient's heart is anterior. Patient's heart is anteriorly located. So in a PA X-ray, the distance between the heart and the detector is nil or very less. ठीक है? So you get a true picture, true size of heart. Whereas in a PA रेडियोग्राफ, PA में क्या है कि आगे से रेज आ रही है एंड पीछे आपके डिटेक्टर है। मतलब पीए व्यू में क्या होगा, हमारा ये वर्टिब्रा बन गई, डिटेक्टर हमारी कमर की तरफ है, अगेन रेज आर कमिंग फ्रॉम दिस साइड एंड हार्ट इज एंटीरियर। नाउ बिटवीन द हार्ट एंड द डिटेक्टर देयर इज सम डिस्टेंस। सो जो हार्ट की शैडो है, इट अपियर्स अ लिटिल बिगर। ठीक है, दिस इज एपी रेडियोग्राफ। सो इन एन एपी रेडियोग्राफ दैट्स व्हाई यू हैव मैग्निफिकेशन ऑफ एंड ये डिफरेंस क्यों होता है? क्योंकि हार्ट एंटीरियर है एंड एपी में हम फिल्म पीछे लगाते हैं। बट अगर हमें पीए में ही फिल्म आगे लगा दी एंड रेस पीछे से लेंगे, तो डिस्टेंस बिटवीन द हार्ट एंड द फिल्म विल बी मिनिमल, देयर विल बी नो मैग्निफिकेशन ऑफ द हार्ट साइज। सो नॉर्मल चेस्ट एक्सरे आप याद रखेंगे, कन्वेंशनली नॉर्मल चेस्ट एक्सरे इज अ पीए रेडियोग्राफ। पीए रेडियोग्राफ, नॉर्मल चेस्ट एक्सरे इज अ पीए व्यू। अभी तक किसी को कोई कंफ्यूजन? एनी कंफ्यूजन टिल नाउ? So three important things we have read. Normal chest X-ray, film focus distance is 6 feet, full inspiration में लेते हैं and it is a PA radiograph. ठीक है? Voice echoing sir. Voice का कुछ करो यार एक बार. हिमांशु एक बार देखो यार, वॉइस का कुछ कर सकते हैं क्या? बच्चे बोल रहे हैं कि वॉइस इको हो रही है। ठीक है, वॉइस इकोइंग सर, वॉइस का कुछ करो यार एक बार। अब तो आई थिंक ठीक हो गई है। आई थिंक इट्स बेटर नाउ। I think it's better now. Can you confirm? Just give me a minute. Now fine, now fine. ठीक है, thank you for that confirmation. Now it's fine ना? चलो, so we have covered that normal chest X-ray PA view होता है, 6 feet distance पे लेते हैं, full inspiration में लेते हैं. Now how to report a chest X-ray? What is the reporting checklist? So दो approaches है. As a radiologist जब हम report करते हैं, we report it from medial to lateral. मतलब हम यहाँ से आते हैं, पहले ट्रेकिया के बारे में कमेंट करेंगे, we comment on the trachea, its bifurcation, look at the heart size, look at the hyla, इसको हम hyla बोलते हैं जो मैं अभी ड्रॉ कर रहा हूँ. Then we look at the CP angle, then we look at the bilateral lungs, and finally bones and soft tissue. So center to periphery, we approach our chest X-ray. So what is the checklist? So first we look at the airways, then the cardiovascular structures, the hilum, the pleura and the CP angles, then the lungs, and then the bones and soft tissues. ठीक है? Right? So this is the approach. So if I were to report this chest X-ray, how will I write? I would say trachea, एक extra page लगा देते हैं, wait. If I were to report this chest X-ray, I would say trachea is central and shows normal bifurcation. Bilateral bronchi are normal. Then cardiac silhouette. Silhouette मतलब shadow. Cardiac silhouette, outline. Cardiac outline is normal in position and size. तो मतलब पोजीशन बोल के मैंने बोल दिया कि डेक्स्ट्रोकार्डिया लीवोकार्डिया नहीं है, इट इज अ नॉर्मल लेफ्ट साइडेड हार्ट, लीवोकार्डियक हार्ट नॉर्मल है. एंड साइज बोल के मैंने बोल दिया कि देयर इज नो कार्डियोमेगली. अब हाउ वी जज कार्डियोमेगली, आई जस्ट कम इन अ बिट. देन थर्ड थिंग आई विल राइट bilateral hyla are normal in position and bulk. Normal in position बोल के मैंने बोल दिया there is no collapse. Normal bulk बोल के I have ruled out that there is no lymphadenopathy. ठीक है. Fourth, I'll say bilateral CP angles are sharp. ठीक है. These are the CP angles. And इनको sharp बोल के I have said that there is no pleural effusion also. ठीक है. तो यही आपको टर्मिनोलॉजी यूज करनी है. वेरी वेरी इंपॉर्टेंट. व्हाट आई एम सेइंग इज वेरी इंपॉर्टेंट. ठीक है. थोड़ा बोरिंग लग रहा होगा बट यही एग्जामिनर्स पूछते हैं आपसे. नाउ लास्टली फिफ्थ पॉइंट पे मैं आता हूँ लंग्स में. बायलैटरल लंग फील्ड्स शो नॉर्मल ब्रोंकोवैस्कुलर मार्किंग्स. Then I say bones and soft tissues are normal. Bones and soft tissues are normal. ठीक है. So this is the normal checklist. इसकी आप फोटो ले लो. I'll also share the PDF. यही आपको बोलना है. Trachea central and shows normal bifurcation. Bilateral bronchi are normal. Cardiac silhouette is normal in position and size. Bilateral hyla are normal in position and bulk. Bilateral CP angles are sharp. Bilateral lung fields show normal bronchovascular markings. Bones and soft tissues are normal. ठीक है. तो इसमें हम देख लेते हैं कि क्या क्या स्ट्रक्चर्स देखे हैं मैंने. So this is the trachea. So trachea is central. ठीक है. And it shows normal bifurcation. This is the left main bronchus. This is the right main bronchus. Now right main bronchus further divides like this. वो आपको नहीं दिख रहा होगा बट मैं बता रहा हूँ. ठीक है. Then what did I say? Then cardiac size is silhouette is normal in position. This is the cardiac silhouette. This is normal in position and size. Then bilateral hyla are normal in position and size. Then CP angles are sharp. And then bilateral lungs show normal bronchovascular marking. ये पूरा जो हमारा lung है, this is normal. Now what are the bones and soft tissues? So this is the clavicle. Again, this is the clavicle. And these are the bones. So this is the first rib. Then this is the second rib. Anterior to posterior जाना है ribs के लिए हमें. This is the third rib, and so on and so forth. एक एक करके आप सारी ribs count कर सकते हो. Now what is this structure? This here is your scapula. ठीक है, this is the scapula. ये बोन्स आपको देखनी ही देखनी है. एंड एज वी गो फॉरवर्ड, अभी आगे वाली प्रेजेंटेशन में आई शो यू हाउ वी सी रिब फ्रैक्चर्स, हाउ वी सी द स्कैपुलर आउटलाइन, क्लैविकुलर फ्रैक्चर्स, सब चेस्ट एक्सरे पे वी कैन जज. Okay, Mahesh is asking, in AP view, if heart shadow is bigger, why will you prefer why you prefer AP view in trauma cases where you want to visualize lung fields and heart? नहीं, ट्रॉमा के साथ क्या इशू है ना महेश, ट्रॉमा के साथ हमारी मजबूरी है कि हमें एपी करना पड़ रहा है, बिकॉज पेशेंट इज हैज एन एक्सीडेंट, वो खड़ा नहीं हो सकता. पीए व्यू में क्या है, 6 फीट दूर खड़ा होना है आपको, लंबी सांस लेके रोकना है. नहीं, ट्रॉमा में हो ही नहीं सकता. ट्रॉमा में पेशेंट हैज कम इन एन इमरजेंसी, यू हैव टू टेक एन एपी व्यू. वो स्ट्रेचर पे लेटा हुआ है, यू हैव नो अदर ऑप्शन. सर प्लीज ऑल्सो कवर इंपॉर्टेंट रेडियोलॉजिकल फाइंडिंग्स इन इंपॉर्टेंट डिजीज ऑफ मेडिसिन. हाँ, आई कवर. ठीक है, सो ठीक है. सो दिस इज द ट्रेकिया डिवाइडिंग इनटू बायलैटरल, ब्रोंकाई एंड सो ऑन. अब ये पूछ रहे हैं कि ये एपी है कि पीए व्यू है. इन माय ओपिनियन इट इज एन एपी व्यू. व्हाई? बिकॉज द स्कैपुला इज ओवरलैपिंग. अभी मैं बताऊंगा क्या है. सो आपने पूछ लिया कि एपी एंड पीए व्यू को कैसे डिफरेंशिएट करते हैं. सो नंबर वन पॉइंट इज यू लुक एट द स्कैपुला, एंड सेकेंड पॉइंट इज यू लुक एट द clavicles. So in a PA view, you have put your hands like this, so the scapula rotate outward in a PA view. So आप देखो, PA view में scapula has rotated outward. It is not overlapping or minimally overlapping. So in a PA view, scapula is rotated outwards away from lung fields. जबकि पीए व्यू में क्या है, पेशेंट के सामने ऐसे पड़े हैं हाथ, तो स्कैपुला लंग फील्ड ओवरलैप करता है. देखो एपी व्यू में दिस इज द स्कैपुला, इट इज ओवरलैपिंग द लंग फील्ड्स. सो इन अ एपी व्यू स्कैपुला ओवरलैप्स लंग फील्ड्स. ठीक है, ये वाला पॉइंट क्लियर है. नाउ सेकंड पॉइंट इज विद रिस्पेक्ट टू क्लैविकल्स. व्हाट हैपेंस विद रिस्पेक्ट टू क्लैविकल्स? सो इन अ पीए व्यू आपने ऐसे पकड़ा था, सो क्लैविकल्स आर लाइक दिस. तो क्लैविकल्स आर लाइक दिस, थोड़ा स्लैंटिंग होती हैं, एंड यू कैन सी पार्ट ऑफ द लंग above the clavicles. So in a PA view, clavicles are slanting and lung apex seen above the clavicles. Whereas in an AP view, apne arms are by the sides. So clavicle is at the top of the lung apex. So clavicle is horizontal and no lung is visualized above the clavicles. Now, third is with respect to heart size. Heart size. So, heart size is less, और we say the heart size. आप इन दोनों में देखो, heart size इस वाले में थोड़ा बड़ा लग रहा है. ठीक है, heart size in a PA view is taken as normal. मतलब हार्ट साइज इज नॉर्मल, माने अगर हमें कार्डियोमेगली बोलनी है, सो विल ओनली से कार्डियोमेगली ऑन एन एपी व्यू, ऑन अ पीए व्यू. Whereas on an AP view, as I explained earlier, there is relative cardiomegaly. Why? Because AP view में क्या था कि डिटेक्टर पीछे था, हार्ट आगे था. So there is a relative magnification of the heart shadow in AP view. So cardiomegaly is only commented in a PA view. ठीक है सर. Sir, will the lung field be same in X-ray taken when the patient is lying and supine? So, good question. Very good question, Aurora Pearl. So, when the patient is standing, the diaphragm is at a relatively lower position. Whereas when the patient is lying down, the diaphragm is at a slightly higher position. So again, lung fields are better seen in a PA view than an AP view. Lungs के लिए आप याद रखो हमें PA ही करना है. AP हमें मजबूरी में करना पड़ जाता है. We are forced to do an AP in situations when the patient can't stand down and take a deep breath. For example, ICU patients. For example, sick patients in the emergency. Or trauma patients who have come to the casualty. We can't ask them to stand up and take a deep breath. We have to do an AP. So for all practical purposes, we will be doing a PA view as far as our heart and lungs are concerned. Yes. Okay. Chalo. So let's first come to the airways part. Just give me a minute. So first, let's come to the airways part. In an airway, what do we comment? We first see the trachea. As I showed you earlier, this is the trachea dividing into the right and the left main bronchus. So this is the right and this is the left main bronchus. So first thing first, right main bronchus. Right main bronchus is short and straighter. मतलब थोड़ा vertical होता है. Whereas the left main bronchus is long and horizontal. ठीक है, थोड़ा लंबा है left main bronchus and as compared to the right it is slightly horizontal. Now right main bronchus further divides into the upper lobe and middle lobe and a bronchus intermedius. So this goes below. This is known as bronchus intermedius. This is the bronchus intermedius. And similarly, the left bronchus divides into the upper lobe and a lower bronchus intermedius. Right? आपको क्या दिखता है? आपको ट्रेकिया एंड मेन ब्रोंकाई दिखते हैं. So airways में आपको देखना है whether they are central or deviated. Now, how do you see central versus deviation of trachea? So I am मिटा रहा हूं मैं आपको. So हमें देखना है center of spinous processes and we join a line. And we see that with respect to this center, how is my trachea? So trachea appears almost in line, thoda idhar idhar, that is fine. Slight deviation of trachea to the left is normal. That is normal. ठीक है, तो एयरवेज में हमने ये देख लिया कि सेंट्रल है कि डेविएटेड है. नाउ दूसरी चीज हम इसी में जो देखते हैं दैट इज रोटेशन ऑफ फिल्म एंड दैट इज एक्चुअली रोटेशन ऑफ पेशेंट नॉट फिल्म. फिल्म हम क्यों रोटेट करेंगे? तो कभी कभी क्या होता है पेशेंट सीधा खड़े होने की जगह थोड़ा ऐसे टेढ़ा ऑब्लिक खड़ा हो जाता है. दैट इज नोन एज अ रोटेटेड फिल्म. So how do we assess the rotation of the film? So we join the center of spinous processes and we outline the medial end of clavicles. तो आप देखो here, the distance of the midline from the right medial end of clavicle is little less as compared to the left hand side. तो अगर मैं इसको A लेबल करूं, B लेबल करूं, so B is more than A. That means patient is rotated to the left. तो स्लाइट रोटेशन ऑफ फिल्म है यहाँ पे. इट शुड बी इक्विडिस्टेंट. नॉर्मली A should be equal to B. तो हमने ट्रेक किया, हमने एयरवे की सेंट्रलिटी देखी, डेविएशन देखा एंड फिल्म की रोटेशन देखी. ठीक है, ये इंपॉर्टेंट देखा हमने. नाउ राइट पैराट्रेकियल स्ट्राइप क्या होता है? देयर इज अ फाइन लाइन नोन एज अ राइट पैराट्रेकियल स्ट्राइप. So this was the trachea. This line is the left wall of trachea, and this line is the right wall of trachea. So this line is known as the right paratracheal stripe, and this is a very very important line because अगर आपको right paratracheal stripe नहीं दिख रही, that means you have some lesion which is abutting the trachea. ठीक है, समझो आपको कि यहाँ पर मल्टीपल लिम्फ नोड्स हैं, तो उस केस में पैराट्रेकियल स्ट्राइप कैसी हो जाएगी? पैराट्रेकियल स्ट्राइप विल बी लाइक दिस. So in that case we will say that the right paratracheal stripe is thickened, or there is thickening of the right paratracheal stripe. Normally right paratracheal stripe बिल्कुल thinned out होती है. It is formed by the right wall of the trachea. So this is the importance of the right paratracheal stripe. Question यहाँ पे बनता है, thickening of right paratracheal stripe is seen in mediastinal ब्रैकेट में right paratracheal lymphadenopathy. ठीक है, मतलब अगर ये पैराट्रेकियल स्ट्राइप थोड़ी थिकेंड है, मतलब यहाँ पर कुछ लिम्फ नोड्स वगैरह मिल सकते हैं हमें. ठीक है, एंड इसमें मोस्ट कॉमन कॉज क्या होता है इसका? मीडियास्टाइनल लिम्फेडेनोपैथी का ट्यूबरकुलोसिस. ठीक है, तो ये क्वेश्चन पूछते हैं एग्जाम में, थिकनिंग ऑफ राइट पैराट्रेकियल स्ट्राइप, mediastinal lymphadenopathy, which mediastinal lymphadenopathy? Right paratracheal lymph node enlargement, and this is most commonly seen in TB. कोई पूछता है which type of TB, primary और post primary? It is primary TB. ठीक है, क्वेश्चन गलत नहीं करेंगे हम. ये राइट पैराट्रेकियल स्ट्राइप की थिकनिंग पढ़ ली हमने. तो थिकन राइट पैराट्रेकियल स्ट्राइप, दिस इज हाउ थिकन पैराट्रेकियल स्ट्राइप लुक्स. सो यू सी दिस मच इज द थिकेंड पैराट्रेकियल स्ट्राइप. ये हमारा ट्रेकिया था. ट्रेकिया इज सेंट्रल, normally dividing into the right and the left main bronchus, and you see that the right paratracheal stripe is so much thickened. Why? Because there are these bulky lymph nodes. CT भी मैंने correlation के लिए आपको लिखा रखा है. राइट पैराट्रेकिया में बल्की लिम्फ नोड्स हैं. इसके साथ साथ यू कैन ऑल्सो सी हाइलम ऑल्सो हैज वेरी बल्की लिम्फ नोड्स. अगेन सीटी कोरिलेशन सेज देयर आर बल्की लिम्फ नोड्स इन द हाइलम एंड मीडियास्टाइनम. ठीक है सर. सो अगेन पैराट्रेकियल स्ट्राइप ये वाली है हमारी, ये ट्रेकिया है, ये लंग है, उनके बीच में दिस इज द पैराट्रेकियल स्ट्राइप विच इज थिकेंड बिकॉज ऑफ दिस लिम्फ नोड. ये क्लियर है कि नहीं? पैराट्रेकियल स्ट्राइप सबको क्लियर है तो आगे बढ़ेंगे. बताओ गाइस, दिस इज क्लियर? Shall we go ahead? Shall we go ahead? ठीक है महेश, thank you for that confirmation. Let's go ahead. So this was our right. This was about our trachea and the paratracheal stripe. Now let's come to other outlines of the heart. So एक हमने trachea की outline पढ़ ली. Now let's see the outline of the heart. हम अब पढ़ रहे हैं heart outline. So हम पढ़ रहे हैं heart, and heart में हमें क्या पढ़ना है? एक तो outline कि which structure form which part of the heart, and दूसरा size, that what is the criteria for cardiomegaly. So outline में structures, क्वेश्चन पूछते हैं structures forming right heart border. Structures forming the right heart border. Right heart border कौन सा हुआ? This is the right heart border. बराबर. So ऊपर से नीचे एक बार देख लेते हैं. So at the top it is formed by the SVC, right atrium. So अगर मैं बात करूं आपका चेस्ट एक्सरे का, just give me a minute. कोई बात नहीं, चलो ऊपर ही देख लेते हैं. चेस्ट एक्सरे तो मेरे में है नहीं अभी. अगर मैं इसी की बात करूं, यहीं पे बात कर लेते हैं. सो एट द टॉप द राइट हार्ट बॉर्डर इज फॉर्म बाय द एसवीसी, द राइट एट्रियम एंड छोटा सा पार्ट ऑफ आईवीसी. डायरेक्ट क्वेश्चन आता है, स्ट्रक्चर फॉर्मिंग द राइट हार्ट बॉर्डर, एसवीसी, राइट एट्रियम एंड आईवीसी. नाउ लेफ्ट हार्ट बॉर्डर स्ट्रक्चर्स फॉर्मिंग द लेफ्ट हार्ट बॉर्डर, ठीक है. लेफ्ट हार्ट बॉर्डर कौन सा हुआ इस वाले डायग्राम में? ये and this is the left heart border. So from the top you have the aortic arch, then the main pulmonary artery, left atrial appendage. Left atrial appendage क्या होता है? Left auricle actually. And then finally the left ventricle. So let's write these things down. Structures forming the left heart border, aortic arch, this is also known as aortic knuckle. ठीक है. Mikil, I'll repeat this in English. Aortic knuckle, aortic arch. So structure forming the left heart border, aortic knuckle, main pulmonary artery, left atrial appendage, and left ventricle. So Makil is from Zambia, which is very nice. We have students joining us from Zambia as well. I didn't know. This is the power of YouTube. You can have students from around the world, and this is the first time that I'm seeing that there's a student from Zambia. Thank you so much, Mikil. Yes, I'll definitely repeat the right paratracheal stripe. So I was saying that normally you see trachea, and this is the left wall of the trachea, and this is the right wall of the trachea. This right wall of the trachea is in direct contact with the right lung, and that's why this is a very thin line, because on one side also there is air, on other side also there is air. So right wall of trachea is in direct contact with the right lung. Now there can be some situations like this, in which your right paratracheal stripe, the right wall of the trachea appears this thickened. And why has that happened? Because now between the right wall of trachea and the lung pleura, there are these bulky lymph nodes. These bulky lymph nodes. Are you able to understand? These lymph nodes are there now. So imagine these lymph nodes are sitting here, and now between the tracheal wall and the lung, there is these bulky lymph nodes which are giving an impression of thickened paratracheal stripe. So this was what I was talking about, thickening of right paratracheal stripe. This is an indication for mediastinal lymphadenopathy. Mediastinal lymphadenopathy. So we were talking about the heart size, structures forming the left heart border and the right heart border. Right heart border is formed by the SVC, right atrium and IVC. Left heart border is formed by the aortic arch, main pulmonary artery, left atrial appendage and left ventricle. ठीक है, Rajesh is from Sindhuli district of Nepal. Oh wow, very nice. Thank you, Rajesh, for being here. I'm really happy to see so many students of so different nationalities. I'm really happy. Just give me a minute. I think I have to put this on charge, otherwise this will shut down. How do I put this on charge? Chalo, let's move forward. So we first see the outline of the structure, and second is we see the cardiac size. So cardiac size is assessed by something known as CT ratio. CT ratio stands for cardiothoracic ratio. Cardiothoracic ratio. Now, normally, cardiothoracic ratio is calculated by maximum diameter of heart divided by maximum diameter of thorax. Mahesh is saying Rishabh Sir is like Pushparaj, not only famous nationally but internationally. Thank you, Mahesh. ऐसा कुछ नहीं है यार. That is the power of YouTube, you know. And I'm really happy that MedEd is doing so good that students from Nepal and Zambia are also in today's live chat. Really happy. ठीक है. So I was saying cardiothoracic ratio is what? Maximum diameter of heart divided by maximum diameter of thorax. Now maximum diameter of heart is calculated how? So you first draw a line from midline, and then you measure the maximum right heart border, maximum distance of this central line from the right heart border, and maximum distance of this midline from the outermost point of the left heart border. This is B. So maximum cardiac diameter will be A plus B. And then what is the maximum diameter of the thorax? At the level of maximum diameter, you measure the thoracic diameter. So let's say this is C. So you divide A plus B by C. So maximum heart diameter divided by maximum thoracic diameter. This will give you CT ratio. Right? Now what is normal CT ratio? So for adults, it is less than 0.5. That is the heart size should be half of the thoracic diameter, half or less than half of the thoracic diameter. For children, this is taken as 0.55, less than 0.55. And for neonates, it is 0.6. Okay? So this is CT ratio. So how do you assess heart size? By CT ratio on chest X-ray. Normally is 0.5. For neonates 0.6. And for children, it is 0.55. Okay, sir. So as you rightly said, Sumapta, Sutapa, sir, how A plus B? Show me once. Okay, I'll again show you. So you first draw a midline. आपने midline draw करी. यहाँ से आप maximum outer diameter of the right heart border. This distance is A. Then from midline, outermost part of the left heart border. This is B. And then you add these two, A plus B. So A plus B becomes your maximum heart diameter. So ये numerator आ गया, A plus B. and then you divide it by the maximum thoracic diameter. This is C. So ये आपका denominator आ गया C, and this is how you calculate the CT ratio. Is this clear? ठीक है सुतपा, Samantha, Dr. Sutapa, this is how we calculate the CT ratio. Normally less than 0.55, 0.5, neonates के लिए 0.6 कट ऑफ लेते हैं. Just give me a minute. Screen is gone. How do I charge my laptop? Yeah, sorry for that. So this was the CT ratio. Now, when we are talking about the heart, we first see whether the heart is enlarged or not. And if the heart is enlarged, which chamber of the heart is enlarged? So as I told you, the right heart border is formed by the right atrium, SVC and IVC. So if the right atrium is enlarged, then what do you get? You get increase in the height of right atrium. So right atrial enlargement, what is the name of the sign? This is increased height of right atrium. ठीक है. Note that right atrial enlargement does not mean that the right heart border bulges further outwards. No, that is not the specific sign. The specific sign is increase in the height of right atrium. And what are the causes of right atrial enlargement? Number one and most commonly asked cause is Epstein anomaly. This is most commonly asked to you in the exam, which is the most important cause of right atrial enlargement, Epstein anomaly. इसके अलावा you can see it in tricuspid atresia, tricuspid stenosis. But you know, tricuspid stenosis is not very common. Rheumatic heart disease में tricuspid involvement is rare. That's why it is not frequently seen. It is frequently seen in an congenital heart disease called Epstein anomaly, in which tricuspid atresia is a part of Epstein anomaly. And that's why you see right atrial enlargement. Okay? In contrast, when the left atrium enlarges, what happens? Now remember, left atrium is a posterior chamber. Left atrium is a posterior chamber. So I'll show you the image, that then only you will understand. So as I told you that left atrium here, see here the left atrium is a posterior chamber. देखो vertebra के पास होता है, पीछे की तरफ होता है. Right atrium ये वाला है. Right atrium is this. This is the right atrium. This is the left atrium. So left atrium is a posterior chamber. Now when the posterior chamber enlarges, what happens? The trachea further bifurcates. So an important sign of left atrial enlargement is widening of carina. So first important sign is widening of carina. Second important sign is straightening of left heart border. Third important sign is double density sign. Okay, I'll tell you what these things are. So straightening of left heart border is that the left heart border appears like straight हो जाता है. इसमें बहुत अच्छे से नहीं दिख रहा है, but I'll show you again few important images where there is straightening of left heart border. देखो, straightening of left heart border like this. ठीक है? Can you see? This is the straightened left heart border. This one, this here. Again, this image, you can see straightening of left heart border like this. This is an important sign of left atrial enlargement. Again, widening of carina is also shown here. And another sign is this double density sign. Now, I'll again show you what is double density sign. Okay. Now, as I told you that the left atrium is a posterior chamber, the right heart border normally is formed by the right atrium. Now, when the left atrium enlarges, it somehow crosses the vertebra and crosses the midline and forms a separate shadow just beneath or just medial to the right atrial shadow. So this is the shadow of the right atrium and this is the shadow of the left atrium. This is known as a double density sign. Double density sign. So it is an indirect marker of left atrial enlargement. And if you draw a line from here to here and you measure this in centimeters, this is the size of the left atrium. This tells you size of left atrium. Okay, so what were the signs? Widening of carina, straightening of left heart border, and double density sign. Now, another important bonus sign I'm telling you, this is known as walking man sign. Okay, I'm not showing you the images of walking man sign. This is a homework for you. This is a homework for you. Search it on the internet, understand how walking man sign is formed, and tell me in the next class. ठीक है, तो 4 साइन बता रखा है आपको: वाइडनिंग ऑफ कैराइना, स्ट्रेटनिंग ऑफ लेफ्ट हार्ट बॉर्डर, डबल डेंसिटी साइन एंड वॉकिंग मैन साइन. ठीक है. Now let's come to Hyla. So we have talked about trachea, we have talked about the heart size, heart outline, heart chamber enlargement. Next we'll talk about hilum. Okay. Now this is the hilum. The thing that I'm drawing, these are the upper pulmonary vessels and these are the lower or descending pulmonary vessels. This is on the right side and this is on the left side. So again a CT correlate the left pulmonary artery, the right pulmonary artery and the left pulmonary artery. So they divide into upper and lower branches and again similarly upper and lower branches like this. So these form the Hila. These form the Hila. Dr. Sutapa is saying, what is Epstein anomaly? See, I can explain you Epstein anomaly, but that is outside the purview of today's class. Just write down that important cause of right atrial enlargement is Epstein anomaly. We'll talk about this when we read about congenital heart disease. You'll also read it in pediatrics, but I don't want to explain it because then class will be very lengthy. Okay. So, Hyla is formed by the bifurcation of pulmonary vessels. Normally, you very well see the right descending pulmonary artery. The right descending pulmonary artery is very well seen. This one. And normal size, matlab this diameter, this normal diameter, it is less than 15 mm in males and less than 16 mm in females. Okay? If it is more, then you can label this as pulmonary artery hypertension. Okay? Enlarged descending pulmonary artery is seen in pulmonary artery hypertension. Okay. So this was regarding the right side. Now on the left hand side, what happens? The descending pulmonary artery sorts of goes behind the heart now. So if you draw a straight line tangent from the outermost part of the left heart border, the Hila sort of forms a concavity. It is medial to this line. But when you see that the pulmonary artery is again bulging outside this tangential line, this means that the pulmonary artery is enlarged. Pulmonary artery is enlarged. So pulmonary artery enlargement ke we have read two signs. Descending pulmonary artery on the right hand side, right descending pulmonary artery more than 15 mm in males and more than 16 mm in females. And on the left hand side, the main pulmonary artery bulges outwards through the tangential line. Through the tangential line from the left heart border. Okay? So remember these two signs, this enlargement and this bulging. These are important signs of pulmonary arterial hypertension on chest X-ray. Now, hilar lymphadenopathy, how do you see? You see this concavity. You see this concavity on the at the level of hila. So this tells you hilar lymphadenopathy. Now let's come to diaphragm. Now normally diaphragm right side is higher than left. And why is that? That is not because liver is on the right side. No, it is because the heart is the central tendon on which the heart rests. It pushes the left side down. Right side is higher than the left because heart pushes the left diaphragm down. And usually if you draw a line from the tangents, okay, if you draw a tangential line between these two, the distance is more than 2 centimeters. Okay, this is normally seen. So normally right side is higher than the left. So between the lungs and the diaphragm, two angles are formed now. This is the CP angle or costophrenic angle. And this one, this is the cardiophrenic angle. Costophrenic angle and the cardiophrenic angle. These are two important angles. Now somebody is saying left side but there is a gastric bubble. Yes. So sometimes you can see this air shadow beneath the left hemidiaphragm. This is actually your gastric bubble. Yes, you're right. Okay, so this is the CP angle that we have labeled. This is the left and that was the right. And these are the two cardiophrenic angles. Cardiophrenic angles. Now let's come to the lung lobes. So हमने trachea कर लिया, heart size कर लिया, hyla कर लिया, diaphragm, CP angle. Now let's come to the crux, that is lung lobes. So first of all, on the right hand side we have three lung lobes, the upper, the middle and the lower. So the division between the upper lobe and the middle lobe is this horizontal fissure. And the division between the middle lobe and the lower lobe is this oblique fissure, also known as the main fissure. This is the oblique fissure. Similarly, on the left hand side, you are divided into two lobes. उसकी भी diagram पे हम आएंगे. So on AP radiograph, this is the projection of the fissures. On the lateral radiograph, this is the projection of the fissure. So this is the horizontal fissure. and this is the oblique fissure. Right? So if I say that the pathology of the lung is in the middle lobe, or I say middle lobe consolidation, so middle lobe is in contact with what? It is in contact with the right heart border. Middle lobe ये है, middle lobe is in contact with the right heart border. So any pathology of the middle lobe, let's say middle lobe consolidation, middle lobe collapse, it will obscure the right heart border because right heart border उसके touch में है. Similarly, any pathology of the lower lobe, this is the lower lobe, it will obscure your right hemidiaphragm. And these are very, very important signs, जो मैं आपको बता रहा हूँ. Similarly, any pathology of the left upper lobe will obscure the right paratracheal stripe because that is in contact with the left upper lobe. So on the right, we have two lobes. So this is the upper lobe, middle lobe, and lower lobe. Again, upper lobe, middle lobe, and lower lobe. So as you can see, on posteriorly, the lower lobe sort of overlaps the upper and the middle lobe. So अगर आप AP पे देखें, so this whole is the lower lobe. It sorts of overlaps. That's why आप कभी-कभी देखोगे कि lower lobe pathologies sometimes appear in upper zones. That is because lower lobe is posteriorly elongated upwards. So any pathology, let's say this is a lower lobe pathology, on an AP radiograph, it will appear as if it is in the upper zone only. And that's why you always need two views, AP and lateral. Okay? Similarly, on the left hand side, we have two lobes, the upper and the upper lobe and the lower lobe. The lingula, remember, is the part of upper lobe only. So this segment is known as the lingula. Lingula is part of upper lobe only, and it is a middle lobe equivalent of the right hand side, but there is no separate fissure, so there are only two lobes, upper lobe and lower lobe, and this is the sort of overlap between the upper and the lower lobes on the left hand side. And lastly, we come to bones and soft tissues. So कभी कभी आपको chest X-ray normal लगता है, but you miss few important spotters. So for example, here you can see there is right clavicle fracture. Here, what is the abnormality? On the left hand side, you can see the breast shadow, but on the right hand side, you see the breast shadow is very small. Why? Because there was a right mastectomy. And similarly, on the left, on this X-ray, what is there? The clavicles appear normal. The trachea appears central. It is dividing into the left and the right. The heart size appears normal. Bronchovascular markings appear little prominent, but there is no consolidation or nodule. But then what is the abnormality? If you look carefully, you can see that there are fracture of these two bones. Okay, so again, these are rib fractures. Rib fractures are very, very commonly missed on chest X-ray, hence you should be very careful while seeing these. Okay, so these were the important chest X-ray findings. These were the important findings, important checklist of chest X-ray. So let's first revise. Okay, I'm disconnecting my screen now. Let's first revise orally only. ठीक है, ऐसे ही रिवाइज करते हैं. ठीक है, मैं बंद कर रहा हूँ अपनी स्क्रीन, थोड़ा रिवाइज करेंगे हम. So tell me, chest X-ray में, how do you start reading a chest X-ray? You first say that the trachea is midline. It is dividing into showing normal division. The right and the left bronchi are normal. Then you come to the heart. The heart silhouette or the cardiac silhouette is normal in position and normal in size. Then we look at the hyla. Bilateral hyla are normal in position and normal in bulk. Then we look at the CP angles. Bilateral CP angles are sharp. Then we come to the lung fields. Bilateral lung fields show normal bronchovascular markings. And finally, bones and soft tissues are normal. Okay, so these are important checklist of how to read a chest X-ray. Chalo. Now let's come to important pathologies now. Important pathologies. So which pathologies are important for us? Consolidation and collapse. These two are important. And then we also look at the patterns of diseases. So for example, consolidation के कुछ patterns होते हैं कि lobar consolidation is seen in certain types of pneumonias. Bronchoalveolar pattern of pneumonia is seen in some other types of pneumonias, and so on and so forth. So perihalar consolidation is seen in some other types of pneumonias. Similarly, collapse. What are the patterns of collapse? And some important chest X-rays like pleural effusion, pneumothorax, lung abscess, hydropneumothorax. All of these will cover today's class. You guys, please tell me in the chat box in the comment section if you think that today's class is getting a little lengthier. Please mention it. I'll be happy to take another class of chest X-ray or other radiology spotters, because again, radiology is a very vast subject. We can't cover everything in one class. I wanted to cover chest X-ray in detail because उसमें students को थोड़ी problem आती है. Students have a difficulty in understanding chest X-ray, especially at MBBS level. PG level पे when you start your PG journey, then radiology is very different. But for MBBS level, radiology is very different. Okay, Sutapa is saying, sir, last lung lobes X-ray, please tell once. Okay. So I was saying on the right hand side, you have three lung lobes, upper. So this is the upper, the middle, and the lower lung. Now, as you can see that the upper and middle are sort of overlapped by this lower lung, because anatomically the lower lung extends superiorly. So this is how the overlap looks like. So this is how the overlap looks like. The upper and the middle are overlapped by the lower lobe. So any pathology, be it in the lower lobe or in the upper lobe, can appear at the same location on an AP projection because वो overlap करना है. And that is why you take two views, AP and lateral. ठीक है Sutapa? This was what I was saying. Now what I will also teach you are zones of X-ray. Something that I've not made a slide for, but it is important. Zones on chest X-ray. Now, on AP radiograph, as I told you, that there is overlap between the upper and lower lobes. Just give me a minute. On AP radiograph, as I told you, that there is overlap between the upper and lower lobes. So, what are the divisions of lung zones? So, as I told you, there is overlap between the upper and the lower lobes on chest X-ray. So, let's say there is a pathology or consolidation here. So, where will you locate this consolidation? What will you say to the examiner? कि sir, ये consolidation कहाँ पर है? So, we have divided it into three zones. The lung fields, we've divided it into three zones. The upper zone includes till the second intercostal space. This is the upper zone. Then from the second till the fourth intercostal space, this is your middle zone. And then all of this remaining one is your lower zone. Remember, these are not lobes, but these are zones of X-ray. Okay? So upper zone is from the lung apex till the second intercostal space. Then from the second till the fourth anterior intercostal space is your middle zone. And below that is your lower zone. So I will say that lower zone ka koi pathology can either be in the right middle lobe or the right lower lobe. बराबर. Similarly, right middle zone ka pathology can either be in the right upper lobe or in the right lower lobe. But ये zones के लिए. And why am I saying zones? Because we have to describe where that pathology is, right? And this is the AP description of AP division of lung lobes. ठीक है? Similarly, So if I say that there is a pathology here, so I'll say this pathology is in the right lower zone, not right lower lobe, right lower zone. Similarly, if I see multiple nodules here, I'll see that there are multiple nodules seen in the right upper zone. Similarly, this is on the left hand side also. The upper two intercostal spaces is the right left upper zone. Then this is the left middle zone. And finally, this is the left lower zone. And so this is how you localize uh, pathologies for description point of view. Now let's see consolidation, collapse, and patterns of disease on chest X-ray. So consolidation is what it is filling up of alveoli, and this can be either filled with water in cases of pulmonary edema, pus in case of pneumonia, and blood in case of alveolar hemorrhage. But all of them will show similar pattern on chest X-ray. So on consolidation, you have filling up of the alveoli. So let's say these are the terminal bronchioles. Apple pencil is discharged. So let's say these are the terminal bronchioles, and they were dividing into multiple alveolar sacs, alveolar ducts थी उनकी, and multiple alveolar sacs थे. Now imagine these alveoli are now filled with, they are now filled with either pus, blood, or something else. So what will you now see? You will now see that there is some filling of alveoli, but the bronchi are still showing air. Okay, this sign is known as air bronchogram. Air bronchogram. And I'll see and we'll study about the various signs, but I'm just trying to tell you the concept. So consolidation is filling of the alveoli, and what sign do you see? Air bronchogram. Now it can either be lobar, in which the entire lobe gets filled with pus, blood, or water. It can be diffuse, that there are multiple patchy alveolar opacification, and it can be multifocal. ठीक है कि कहीं इधर है, there are some patches here, some patches here, some patches here, some patches here. Now second is interstitial opacities. Now between the alveoli and the blood vessels, you have some interstitial or interstitium tissue through which gaseous exchange happens. If you have some opacities or pathology in that area, you see these linear lines. Okay, these are how interstitial opacities look like. Now, atelectasis is what? Atelectasis is collapse. So whenever alveoli will collapse, all the air will come out of them. So they will also appear homogeneously white. Atelectasis also appears white. And there are patterns of atelectasis. Now what is a nodule? Nodule is defined as radiopacity, which has a very well-defined border, and mass is also radiopacity with very well-defined borders. But what is the difference between the two? Nodule is less than 3 centimeter, and we label it as mass when it is more than 3 centimeters. So less than 3 is nodule, more than 3 is a mass. And these are the various common lung pathologies that you will encounter on chest X-ray. So let's first come to consolidation. So consolidation is what? Radiologically replacement of alveolar air by either fluid, blood, pus, cells, or some other substances. Now, if it is the air is replaced by fluid, then you label this as pulmonary edema. If it is replaced by blood, we call it pulmonary hemorrhage. Pus is your regular pneumonia. Cells is eosinophilic pneumonia में दिखती हैं आपको cells. And sometimes some other substance like a surfactant deficiency may other substance can also accumulate inside the alveoli, and us condition ko we call it pulmonary alveolar proteinosis. Remember in Robbins you have read PAP, pulmonary alveolar proteinosis. It is the same thing. Now consolidation mein what did I tell you? If this is the bronchi, It's bronchioles, terminal bronchioles, further dividing into the respiratory bronchioles. And these are multiple alveolar sacs, right? Now, there is no volume loss which happens in consolidation. The existing alveolar air is now replaced by something else, either pus, fluid, blood, or cells. So, there will be no volume loss. So, there will be no crowding of ribs, no pulling up of Hila, no tracheal deviation. So, no volume loss meaning there will be no tracheal deviation, no fissural deviation, no hilum deviation, no crowding of ribs. No crowding of ribs. Okay. So in this X-ray, what do you see? You see fluffy opacity in the right middle zone. The trachea is still central. The diaphragm is not pulled up. And the right hila appears slightly bulky. Okay. And there are some other opacities also. Some other reticular opacities as well throughout the lung. So this is how a consolidation looks like. Okay. Now let's see other types of consolidation. What are the various signs in consolidation? So you will either see a homogeneous mass obscuring vessels. So vessels will not be seen through this homogeneous mass, but you will be able to see these air bronchograms. Can you see this? These branching air-filled opacities. What are these branched air-filled opacities? They are air bronchograms. So air bronchogram. This is one important sign of consolidation. Again, what do you see here? You don't see any air bronchogram, but you see these fluffy cloud-like opacities. So these are ill-defined patchy opacities. इनको हम बोलते हैं cloud-like opacities. These are also consolidation. This is not a collapse. Okay? And sometimes you can see air alveolograms. Okay? This is not an important sign at your level, but just remember the name. So air bronchogram is asked by faculties. This is asked in your viva also. This is a sign of consolidation. Now, what are the patterns of consolidation? You can have the entire lobe consolidation. So for example, here the right upper lobe shows homogeneous consolidation. This is a lobar consolidation. In this case, what is the name of the sign? This is bulging fissure sign. And this is seen in what? This is seen in Klebsiella pneumonia. Now, sometimes you can have diffuse patchy consolidation. So, for example, multiple patchy consolidation seen in bilateral lungs. Now, this can have various causes. It can be seen in bacterial bronchopneumonia, viral pneumonia, ARDS, or pulmonary hemorrhage. And third pattern is a perihilar consolidation. Okay, perihilar consolidation. This is also known as bat wing consolidation. एंड इसके दो इंपॉर्टेंट कॉज होते हैं. नंबर वन इज पल्मोनरी एडिमा. Pulmonary edema. And second cause is, can someone tell me what's the second cause of this perihilar consolidation? In the chat box, can someone tell me? What is the second cause? Can someone tell me in the chat box? Okay, no issues. So pulmonary edema एक cause है. Second cause is PCP pneumonia. This you see in HIV patients. तो हिस्ट्री में HIV पॉजिटिविटी मिलेगी. एंड दोनों में डिफरेंशिएट और कैसे कर सकते हैं? पल्मनरी एडीमा में यू विल सी प्लूरल इफ्यूजन, बट पीसीपी न्यूमोनिया में यू डू नॉट सी एनी प्लूरल इफ्यूजन. नो प्लूरल इफ्यूजन. Okay, that's how you differentiate between these two. So patterns of consolidation में lobar consolidation, diffuse patchy consolidation and perihilar consolidation. Others can be a peripheral consolidation कि center में कुछ नहीं है, only periphery में there is consolidation. This is known as a reverse batwing sign. Reverse batwing sign, and this is seen in ARDS. Another type, and this is very important because examiners love to ask this, aspiration pneumonia में. Aspiration pneumonia में कौन सा पैटर्न मिलता है? So here you see predominant right sided consolidation, and right में भी lower zones are affected. And why is that? Because जब भी aspirate करते हैं तो as I told you, the right bronchi is more vertical, the left bronchi is horizontal. So aspiration is more common on the right hand side, and the right lower lobes are more commonly involved. So aspiration pneumonia में right lower lobe involved more than upper lobes. ठीक है? Good. Now this was consolidation. Next we move to collapse, and as the definition, as I told you the concept, collapse is what? Alveoli sick, air chali gayi. Alveoli don't have any air now. So there are features of volume loss. There are features of volume loss associated with decrease in amount of air within the alveoli. Now what are the features of volume loss? Displacement of fissures. So fissure can be pulled up or pulled down. Crowding of vessels. So पहले पहले आप CT में देखोगे कि vessels are crowded with each other. Diaphragm elevation, hilar displacement, mediastinal shift, crowding of ribs. Now air bronchograms can also be seen in collapse, remember, and it is a known fact. So air bronchogram is not a specific sign. Remember, air bronchogram is not a specific sign of consolidation. Bat-Turing sign, please show once. Bat-Turing sign का मतलब bat wing sign था यार. Sorry, that was bat wing consolidation. Sorry, that is not Bat-Turing sign. That is a bat wing consolidation. So perihilar, meaning around the hilum of the lungs, you see consolidation. This is known as perihilar consolidation, and it is seen in pulmonary edema and PCP pneumonia, pneumocystis cerevisiae pneumonia. Lobes and zones, how to separate? So it is very difficult to separate it on chest X-ray because you don't see the minor fissure or the major fissure on chest X-ray. Whenever you're describing any opacity, you stick to the zones. For example, if I were to describe this chest X-ray, I would say there is a homogeneous opacity seen in the right middle, right upper and middle zones. It is obscuring the vessels, and the right horizontal fissure is bulged downwards, giving a bulging fissure sign. So what have I described? I have described it as a homogeneous radiopacity in the right middle and upper zones, right upper and middle zones. तो एक्सरे पे आपको जोन्स ही बोलने हैं. ठीक है सुतपा? Sutapa is saying, why aspiration pneumonia? Lower lobes more common than upper lobes. So if you are standing and you're aspirating, by gravity, the aspirate will go to the lower lobes. But yes, you're right. If you're lying down and then aspirating, the aspirate goes to the upper lobes, posterior segment. This I didn't tell you because thoda sa specific ho jata. I didn't want to be so specific, but that is the reason. When you're standing and aspirating, then the aspirate goes to the right lower lobes. So I was telling you collapse. The hallmark of collapse is volume loss. Now, what are the types of lung collapses? So there are some named signs. So two important signs we'll read with respect to lung collapse. In fact, there is only one named sign. So first is pulling up of right minor fissure. So this is the minor fissure. This is pulled up like this. This tells you that what type of collapse is here now. There is collapse of the right upper lobe. This is a right upper lobe collapse. Now this is an important sign here. The arrows are pointing towards an important sign. First, I'll tell you the name of the sign. The name of the sign is Lufficial sign. Now, what is this Lufficial sign? It is seen in left upper lobe collapse, and this is this thin sickle shaped air pocket surrounding the aortic knuckle. And now, what happens in the left upper lobe collapse? Left upper lobe forms sort of a, whenever it collapses, it becomes anterior to the left lower lung. Now, when it comes anterior to the left lower lung, it forms a wheel like opacity, पर्दा type गिर जाता है left lower lung के ऊपर. And hence you see this increased whale like opacity on the left hand side as compared to the right hand side. In addition to this, what happens? The superior segment of the left lower lobe bulges and surrounds the aortic knuckle. This is known as Lufficial sign. This is a sign of left upper lobe collapse. Left upper lobe collapse, Lufficial sign. Now, sometimes what happens, if you look at this chest X-ray, you will see that the left hemidiaphragm goes medial to the left heart border. मतलब it crosses the left heart border. देखो यहाँ पे भी left hemidiaphragm crosses the left heart border till here. Now, in a left lower lobe collapse, what happens? In a left lower lobe collapse, the collapsed lung goes behind the heart. And hence, sometimes you're not able to see the left lower lobe collapse. But what you will see a retrocardiac shadow. You will see a retrocardiac shadow, and the left hemidiaphragm is silhouetted. ठीक है, उसकी outline is now blurred because the collapsed lung is in contact with the left hemidiaphragm. So this is left lower lobe collapse. Left lower lobe collapse. Similarly, this is an important sign again. यहाँ पर कौन से लोब का collapse हुआ है? This is right upper lobe collapse. But an important sign which is shown here is golden S sign. Golden S is what? एक side there is concavity, but then there is convexity here because there is a hilar mass. So hilar mass causing right upper lobe collapse gives you this golden S sign. So this is seen in hilar mass causing right upper lobe collapse. The golden S sign. Now here, tell me which lobe is collapsed here. This is the radiopacity. What is it causing? It is causing obscuring or silhouetting of the right heart border. So this is the right middle lobe collapse. There is silhouetting of right heart border. Of right heart border. Now tell me in this X-ray which lobe is collapsed. You can see a fine demarcation between the lungs, a normal lung and the collapsed lung, and the right hemidiaphragm is not visualized. That means which lobe is now collapsed? This is the right lower lobe collapse. The right lower lobe collapse. So have you guys understood? Left में क्या होगा, right में क्या होगा? Whenever there is collapse, that part of the mediastinum which is in contact with that collapsed lung will get obscured, will get silhouetted. So localizing consolidation and collapse, we use the silhouette sign. Normal silhouette is a normal outline of the lung, of the mediastinum. Now, whenever a lesion is in anatomical contact with the part of the mediastinum and it has the same density as that part of the mediastinum, it will obscure that mediastinal structure. For example, right heart border will be obscured in right middle lobe collapse. Right hemidiaphragm will be obscured in right lower lobe collapse. Left hemidiaphragm will be obscured in left lower lobe collapse, and so on and so forth. This is the normal silhouette sign. So Tapa is saying, why is a silhouette seen? Silhouette is what? Shadow. कैसे बताऊं आपको? मान लो मैं लाइट के सामने खड़ा हूं यहाँ पे. I am standing in front of the light. The shadow is now falling on my face. Similarly, when any structure is coming in the way of X-rays, that shadow is formed on the film. Okay, that is the normal way of acquiring any chest X-ray, and that is the normal silhouette. Silhouette is the normal outline of any structure. Okay, so localizing consolidation, obscuring of the right paratracheal stripe is right upper lobe collapse. Right heart border obscured, you have right middle lobe collapse. Right hemidiaphragm obscured, right lower lobe collapse. Aortic arch obscured, left upper lobe collapse. Left heart border obscured, लिंगुला का कोलैप्स है भाई. एंड अगर लेफ्ट हेमी or left descending or aorta is obscured, then there is a left lower lobe collapse. Okay, so these are the important mediastinal structure which you should remember. अगर वो नहीं दिख रहे मतलब उनके adjacent lung lobes have either collapse or consolidation. For example, look at this. Here the right heart border is seen, but the right hemidiaphragm is obscured, silhouetted. So right hemidiaphragm silhouetted, this is right lower lobe involvement, right lower lobe collapse. Here the right paratracheal stripe is silhouetted. So this is the right upper lobe collapse. Again, right middle lobe will obscure the right heart border, and the left heart border obscure है तो कहाँ का collapse है? Lingula, lingular segment of the left upper lobe collapse. Is this clear? Clear है? Again, aortic knuckle obscured है तो left upper lobe collapse. Left hemidiaphragm obscured है तो right left lower lobe collapse. So these are the important signs and structures. Now again, this is something known as opaque hemithorax. कि एक side of lung is completely white, white out lung जिसको हम बोलते हैं, opaque hemithorax. Now, whenever one-sided lung is collapsed, there can be two possibilities. Either there is gross pleural effusion, this will obscure the entire hemithorax, or there can be complete collapse of the right lung. Now, how will you differentiate? You look at the trachea. In a opaque hemithorax, next step is to look at the trachea. Now, if the trachea is deviated to the side of opacity, मतलब जिस साइड opacity उसी साइड ट्रेकिया भी डेविएटेड, जैसे कि यहाँ पे ट्रेकिया इज डेविएटेड like this to the same side as opacity, that means there is a collapse. But if the trachea is deviated opposite to the side of opacity, then that means there is pleural effusion. मतलब अगर इसी केस में अगर ट्रेकिया यहाँ पर होता हमारा और ऐसे डिवीजन चल रहा होता, that means that यहाँ पर there is some big mass or pleural effusion which is pushing the trachea away. So this is either pleural effusion or a large chest wall slash pleural mass. Okay, is this clear? Opaque hemithorax. Next step is to look at the trachea. If it is deviated to the same side as the opacity, you are dealing with a lung collapse. If it's deviated to the opposite side of opacity, you are dealing with a pleural effusion or a large chest wall or a pleural based mass. So these were the important concepts in your chest X-ray, important nodule, important pathologies. Now, few pathologies I'll cover as spotters. So tell me how we describe this chest X-ray. So I'll say this is a chest X-ray, PA view of, let's say, of a 54-year-old male. Uh, the trachea is central and shows normal division. Right and left bronchi are normal. Cardiac silhouette is normal in size and position. Bilateral CP angles are sharp. Diaphragm are normal in position. The main pathology is seen in the form of a cavity in the right upper and middle zones. The cavity has thin walls and there is an air fluid level within this cavity. So, what are the important positive findings? Cavity with thin walls and air fluid levels. What is air fluid level? This is fluid and this is air. And whenever there is an air fluid level, you will see a horizontal line in between these two. Okay? So this is air fluid level and it tells you there is fluid within a cavity. And this is hallmark of an abscess, lung abscess. This is hallmark of a lung abscess, cavity with air fluid level. Now spotter number 2. This is what is typical of tuberculosis. So how will I describe this chest X-ray? So this is let's say a chest X-ray of a 35-year-old female. Why am I saying female? Because I can see breast shadows here. Okay, so this is likely a female. So 36-year-old female, chest X-ray, PA view. Trachea is in midline, shows normal division, bronchi normal, heart size normal in position and size, CP angles are clear. Main pathology is seen in the form of multifocal patchy consolidation in the right upper and middle zones with multiple nodules adjacent to these consolidation. So multiple patchy consolidations in the right upper and middle zone with adjacent nodules. Now, this is hallmark of tuberculosis. तो डिस्क्रिप्शन क्या है इसका? मल्टीपल पैची consolidation in right upper zone and right middle zone with adjacent nodules. There is no pleural effusion, no obvious lymphadenopathy. So this is hallmark of TB. Now TB में क्या होता है? TB is of two types. There is primary TB and then there is a post-primary TB. Now, in a primary TB, we've read in pathology, there is a Gons focus, there's a Gons complex, and then there is a Ranke's complex. So, Gons focus में क्या था कि right upper lobe में there will be a focus of infection. The draining lymphatics will drain that focus of infection to the ipsilateral mediastinal lymph node. So, in a primary TB, what happens? The lung is usually normal. And what you typically get is ipsilateral or unilateral, sorry, you get unilateral paratracheal lymphadenopathy. Okay, so sometimes paratracheal, sometimes hilar or paratracheal lymphadenopathy. So you can see these bulky lymph nodes. Again, the right paratracheal stripe is thickened. Can you see here? This is what I was talking about. This is the paratracheal stripe. It is thickened here. It is abnormal. It has to be suspicion of TB has to be raised. These are what bulk, most likely यहाँ पर bulky lymph nodes होंगी. So in a primary TB, your lung appears normal, but you get Hila and mediastinal lymphadenopathy because of Ghon's focus, Ghon's complex. Now usually this is self-resolving. Usually primary TB in an immunocompetent patient converts to latent TB. ठीक है, calcified रहते हैं lymph nodes, again that focus of infection gets calcified, it becomes latent TB. But if this patient is immunocompromised, not competent, it is immunocompromised, then that infection can turn into progressive primary TB. A progressive primary TB now has a hematogenous spread. That means it has now spread, it will now spread through blood. So in the lungs, what happens? Now multiple tiny millet-shaped nodules scattered throughout the bilateral lungs from upper to middle zone. Okay, there is no upper lobe predilection, there is no lower lobe predilection. It is bilateral and tiny millet-shaped nodule sized. So this appearance is known as miliary TB. This appearance is now known as miliary TB, right? Apart from lungs, what happens? So miliary TB happens in the lungs. It can also spread to the spleen, to the liver, to abdominal lymph nodes, etc. And liver and spleen, maybe you see multiple tiny hypoechoic or hypodense nodules on CT or ultrasound. Now, this was an immunocompromised patient when progressive primary TB happens. In an immunocompetent patient, the TB bacilli undergoes latency. It sits quietly in the lung and it waits for an appropriate timing when there is immunosuppression. So let's say patient is receiving chemotherapy or patient has cancer, he has diabetes, he has CKD, all these are immunocompromised states. So in such scenario, or let's say patient has AIDS, HIV AIDS. So in such scenario, there is reactivation of TB. And this is what is known as post-primary TB. So in a post-primary TB, or let's say patient has very less weight, thin build. So in such cases, you see the TB bacilli reactivates. Now, when it reactivates, it most commonly affects the right upper lobes. Mainly the upper lobe, not right or left, upper lobe mainly. So in post-primary TB, first of all, upper lobes are affected. And what do you get? You get consolidations. You get tree in bud nodules. Tree in bud nodules. You get necrotic lymphadenopathy. And cavities. So let's look at this chest X-ray. Here I can see a cavity in the right upper lobe with surrounding consolidation. There are no obvious nodules that I can see. जब मैं इसका CT करूंगा, देखो लेफ्ट हैंड साइड पे भी है, लेफ्ट हैंड साइड में भी थे इसके कंसोलिडेशंस अपर जोन में. जब मैं CT करूंगा, so in addition to consolidation, ये cavity है, surrounding consolidation है. I can also see these nodules. Now these nodules are given a special name, tree in bud nodules. And this tells me that there is endobronchial spread of TB present. Endobronchial spread. It tells you endobronchial, TB nahi, endobronchial spread present. So like multiple buds in a branch of a tree, you have multiple nodules along the bronchi. Why? Because all the bronchi surrounding a particular respiratory bronchiole are now affected with this TB. Routine blood nodules, one of the causes is tuberculosis. And these are how necrotic lymph nodes appear. Can you see here that the center of these lymph nodes are dark? The center of these lymph nodes are dark. This is necrotic lymphadenopathy. Lymphadenopathy. And on CT, how do we identify necrosis? You have hypodense center. So lymph nodes are enlarged and the center is hypodense. That means it has necrotic lymph nodes. So hallmark of post-primary TB is consolidation, train blood nodules, necrotic lymphadenopathy, and cavities. So all these are important X-rays of tuberculosis. So you can see here multiple patchy consolidations in the mainly the middle zone. Again यहाँ पर bilobar disease है, right middle and right side and left side. Again these are patchy consolidations seen in the bilateral upper and middle zones. All these are X-rays of tuberculosis. Now next spotter is this pleural effusion. So pleural effusion में what sign do you see? You see this meniscus sign. So the lateral edge of this radiopacity rises up like a meniscus sign of a mercury. So this is name of sign is meniscus sign. And this meniscus sign tells you that this pleural effusion is a free pleural effusion. मतलब पानी free है, कोई septations, कोई loculations नहीं है. And which is the investigation of choice for pleural effusion? It is ultrasound. It is ultrasound. Okay, so investigation of choice for pleural effusion is ultrasound. And what do we see on ultrasound? On ultrasound, fluid appears black. So you will see wherever there is pleural effusion, that area is appearing black. And another advantage of of ultrasound is that you can use ultrasound to put in some drainage tubes as well in this pleural effusion, like a pigtail. So again, ultrasound is the investigation of choice for pleural effusion. Okay, next spotter. So next spotter is pneumothorax. What is pneumothorax? Air in the pleural cavity. Now, a very important sign of pneumothorax on a chest X-ray is that you should not see vessels going into this black opacity. That means that these are not lung. This is not lung. This is free air in the pleural cavity. See on the left hand side. On the left hand side, I can see vessels going till the periphery. Whereas on the right hand side, the vessels are limited till this part only. I can see a pleural line, and beyond this pleural line, I am not seeing any vascular markings. That means this air is outside the lung, it is into the pleura, and this is pneumothorax. This is pneumothorax. Now, for pneumothorax, the investigation of choice is NCCT. And on NCCT, again, this is confirmed that the lung pleural outline is seen separately. Outside this pleural outline, you can see air. And this tells me this is pneumothorax. This is air in the pleural cavity. Now, apart from CT and X-ray, can I pick up air on ultrasound? Yes. On ultrasound, what are the signs? So on B mode ultrasound, I get absent absence of lung sliding. So what is lung sliding? Now, when you do an ultrasound, if this is the chest wall, this is the lung, I take a deep breath. What happens to the chest wall and the lung? The chest wall is stable. The lung moves like this. This is normal sliding of pleura over the chest wall. And I can visualize this on an ultrasound. I put the probe, I can see the pleura moving over the chest wall. Now, in a pneumothorax, this sliding of lung is absent. This is known as absence of lung sliding. This is a sign on B mode ultrasound. And remember, another important sign on B mode ultrasound is lung point sign. Lung point sign. Now, what is this lung point sign? Now, air, because it is lighter, accumulates in the upper part of the chest. So, if I do a ultrasound in the upper part, what will I see? Chest wall, lung. There is no movement. Why? Because there is air in between these two. But as I come down doing an ultrasound, I will see a point when there is lung sliding present. तो मतलब उसके ऊपर pneumothorax है, उसके ऊपर pneumothorax नहीं है. And this confirms that yes, there is a part of lung which has a pneumothorax. And so visualization of the lung point sign on B mode ultrasound is the most specific sign. Most specific sign of pneumothorax. Okay, this is the lung point sign, very, very important. Now on M mode ultrasound, what is the name of the sign that I see? It is barcode sign, also known as stratosphere sign. Okay, so when there is no motion between the chest wall and the lungs, I put in an M mode. What do I see? I see horizontal lines. Why? Because there is no movement. So this is your barcode sign. Whereas the normal lung, because it slides over, if I put in an M mode, you will see movement, multiple movements. It looks like a seashore sign. It is known as seashore sign. So normal lung shows seashore. Pneumothorax में I get barcode. So normal lung, seashore. How do you remember whether seashore is normal or abnormal? So normally you go to the sea, right? When you're happy, you go to the sea. So normally I go to the sea. So seashore sign is seen in a normal lung. And barcode sign is seen in pneumothorax. Clear? Is this clear? Should I move ahead? Okay. Now let's move on to the next spotter. So we have done with pneumothorax. We have done with pleural effusion. Now let's say there is a scenario in which both air and fluid are there in the pleural cavity. What will that be? It is hydropneumothorax. So hydropneumothorax is both fluid and air in the pleural cavity. And what do I see here? I see an air fluid level within the pneumothorax. So you will have features of pneumothorax plus air fluid levels. And what is the treatment? Treatment is either an ICD insertion or a PCD insertion. So ICD insertion आप याद रखिए. This is a treatment for hydropneumothorax. Barcode and seashore, tell once again, नहीं समझा. So first of all, these are seen on M mode ultrasound. So for that, you need to understand what M mode ultrasound is. So M mode में हम क्या करते हैं कि नॉर्मल बी मोड चल रहा है, उसमें एक पॉइंट इन टाइम पर हम लाइन डाल देते हैं एंड देन वी ट्रेस दैट line with respect to time. So since in a pneumothorax, between the chest wall and the pleura, there is no air. If I put in a cross-sectional time and trace this, let's say this point I'm tracing with respect to time, there is no movement of this, right? So it will appear like a straight line. Similarly, multiple lines, here if I put, all will appear like straight lines. This is a barcode. This appears like a barcode, right? That's why it's known as a barcode sign. What is a seashore sign? Normally, seashore sign is seen. The lung moves over the chest wall. So if I put multiple point and trace them over time, you will see multiple movements and it appears like a seashore. Just remembering the name is also sufficient. Seashore sign normally, barcode sign seen in pneumothorax. Now, spotter number 3, what do I see here? So again, this looks like a thin-walled cavity. Yes, it is a thin-walled cavity. But within this cavity, I can see that there is a rounded radiopacity within. So what is this? Can somebody tell me what is the name of this sign? This is known as Monod's sign, also known as air crescent sign. And where is this seen? It is seen in aspergilloma. This is seen in aspergilloma. Next, again, name of the sign and diagnosis. The name of the sign is finger in glove appearance. And the diagnosis is ABPA. ABBA stands for allergic bronchopulmonary aspergillosis. Allergic bronchopulmonary aspergillosis. Now, what happens in ABPA? So, first of all, findings of ABPA are there is central bronchiectasis, mainly in the upper lobes, with mucus plugging. Now, what is the meaning of the word bronchiectasis? Dilatation of bronchi. So, if this is the normal chest X-ray, in the upper lobes, the bronchi are dilated, right? Upper lobe bronchiectasis. And within these bronchiectasis, I have mucus plugging. So, mucus fills these dilated bronchi. And that's why they appear like these linear shadows. Because bronchiectasis में तो air होनी चाहिए थी, but उसके अंदर mucus फंसा हुआ है. So they appear like linear shadows in the upper lobe, like fingers fitting into gloves. That's why the word finger in glove appearance. Okay, I know it's sort of a forced way to make a sign. You don't really need to name it a sign, but you know, because you have named it, it becomes catchy. It's easier to remember. So finger in glove appearance seen in ABPA. Next spotter. What is this? So you see again multiple dilated bronchi, and this is how bronchiectasis appears. Multiple dilated air-filled bronchi. ठीक है, कुछ गोल गोल है, some are rounded, some are linear. This is what is a bronchiectasis. This is bronchiectasis. And what are the signs that you see in bronchiectasis? Number one is tram track appearance. And on CT scan, you see something known as signet ring sign. Signet ring sign. Now, next is this spotter. What is this appearance known as? So, this is known as cannonball lesions. ठीक है, when you do a paintball, paintball जो आप करते हो ऐसे गोल गोल धब्बे पड़ जाते हैं. So, cannonballs, these are cannonball lesions. And these are very well defined, multiple, varying size lesions scattered throughout the bilateral lungs. These are known as cannonball lesions and they suggest metastasis. Now, which are the important metastasis to the lungs? Which primary lung cancer metastasize? Remember choriocarcinoma. Also remember RCC, lung cancer तो है. Okay, so these are cannonball mets or cannonball lesions. So this was regarding chest X-ray. I want to stop here. I don't want to cover bone lesions now, although we have a little time to cover bone lesions, but it will be little too much because a lot of students have are here with us for the past 2 hours. If I take bone tumors, then it will be a little rushed up topic. I don't want to take some bone tumors because it is again a very big topic to cover. So let's take a pause here. I'll ask the team to schedule another class for radiology spotters, for radiology Farre. I'll cover bone lesions again and some other topics also which are asked in ENT, in surgery, in obs and gynae, right? So that is all for today's class. Thank you so much for coming. Main idea was to discuss how to read chest X-ray and important radiology spotters for chest. Okay. Now, if you have any doubts, any queries, please mention them in the chat. I'll be happy to take them. Thank you, Jessica, for that $10 US dollars. I think uh, they will be credited to the MedEd account. But thank you so much for the $10 comment. Happy New Year. Thank you for building better world with your instructors. Thank you, Jessica. Happy New Year to you as well. Which country are you from? Can you tell me? Jessica Om Isaac. Okay, Aurora Paul is from Kenya. Nice. So we have members from, okay, Gainesville, Florida, USA. Oh, lovely. This is the first time I'm seeing so many varied people joining us on MedEd. So lovely to see. Hydropneumothorax, please show once. Okay. So first of all, what does hydropneumothorax mean? So hydropneumothorax literally means both hydro, that is water or pleural effusion, and pneumo, that is air. So in the pleural cavity, you have both air and water. Now, whenever there is air and water somewhere, let's say in this bottle as well, okay, ये तो Mr. India वाली bottle मिल गई. Let's say in a glass of steel glass, I have half filled water. So whenever there is air and water together, they'll always form a level because of surface tension, right? Because of surface tension. So whenever there is both air and fluid in the pleural cavity, you see this air fluid level like this straight line. Can you see this straight line? This tells you there is hydropneumothorax. And this is like a most common spotter that is asked in final prof viva, medicine viva. Tell me what is this? This is hydropneumothorax. Thank you, Mahesh. Thank you. Yes, Boys Official 3180. You're right. I'll use full English from next time. I didn't know that actually so many students from various different countries join. And it is very heartwarming for me and the whole MedEd team, I think. I'll try to be in English completely from next time. Thank you for that feedback. Mahesh is saying, I got better confidence now to report through to read chest X-ray. Yes, that was the main aim. Chest X-ray is the bread and butter. And as an MBBS graduate, you will be asked to read chest X-ray. You'll get posted in primary health centers, sub-district hospitals, and then it is important for you to recognize abnormal chest X-ray. And I really hope this class helped. ठीक है, thank you so much. Thank you all so much for joining. If you, I'll also share my contact details. By the way, if you some of you want to reach out to me on Instagram, my Instagram handle is dr.rishabh. Sorry, I'll write it again. Wait, it is dr.rishabh 2970. Okay, this is where you can search me on Instagram. This is the monod sign. This is not the Murud sign. This is the monod sign, Sutapa, that in a pre-filled, preformed cavity, the fungus colonizes. Aspergillus fungus colonizes. So in a preformed cavity, the fungus colonizes and it forms a fungal ball. This forms a fungal ball, and so whenever the patient stands, you have an air crescent between the fungal ball and the cavity. This sickle-shaped air is known as the air crescent sign or the monod sign. Okay, Yuvraj is asking, sir, I have a query regarding the one plan. So yeah, I know a lot of students have purchased the one plan earlier, slightly expensive, but I had a word with the team. So all your plans will be now converted to the 5.5 years full master plan. So irrespective of whatever plan you took, let's say आपने 3 years का 30K में लिया था पहले, उसमें let's say there was no test and discussion, nothing else. Now all of you will be updated to a single plan, 5 years या 5.5 years का, in which you'll get everything. So unfortunately, no refund can be offered at this stage, but all the other services of MedEd will be upgraded in your plan. So yes, Mohit, aspergillus does show fungal ball in the lungs if there are preformed cavities. For example, in cavities of tuberculosis, which are no longer active, but they become home of aspergillus fungus, or bronchiectasis. Let's say patient had bronchiectasis earlier. Now the dilated bronchi become home for aspergillus fungus. And this is a colonizing form of aspergillus, an aspergilloma. Yes, pass positive fungus is this aspergillus. So that is all from my side today. Thank you so much for joining. I'm really happy to see the response. Uh, Students joining from Kenya, from Florida, USA, from Nepal, from Zambia. Okay, I didn't know that students were joining. Thank you so much, and I'll hope to see you guys in the next class.